Thank you very much. It's a real pleasure to be here with all of you and to get to start things out. Let me begin by thanking Donna Harrison and Christine and all the organizers who have put so much laboring of love into this possibility here, and I'm very grateful to be able to be a part of it in this way. I also thank Christ Medicus and their kindness in sponsoring this session, and I thank you all for being here tonight and for allowing me to consider a pretty wordy title with you all. And you can see it's a big picture sort of talk, and when I think about matters Hippocratic, the first thing I suppose I'd like to do is to remind us, of the Hippocratic Oath. Some of you who know this area know that there's something called the Hippocratic Corpus, and that's all these writings that fall under the umbrella of this so-called Hippocratic school. And it's my own sense, if you're like me, you probably refer more often to the Hippocratic Oath than you could actually recite it by memory, right? And if you just look at that, you're reminded of the kind of content that is included. And so when we talk about the Hippocratic tradition and being Hippocratic physicians or healthcare workers in different ways, in one sense, people are entitled to say, oh, you mean like the oath? And then look at that and say, oh, so you don't do surgery. And I say, you're correct, I'm an internal medicine doctor, I don't do surgery. But of course, there's obviously some things in here that we say, well, that was from a different time, a different context, etc. So I know you know that. And then if we were to say, well, okay, how about the Hippocratic tradition, especially as it was, merged with the Christian tradition in the West, we can think of a number of other kinds of things that we would want to fold into what we would say, at least about ourselves, that make us practitioners within the spirit of the Hippocratic tradition. Right? So that's just sort of a way, by way of qualifying what we might mean. So I think we have to explain ourselves, but I think it's fair to say also that despite whatever historical peculiarities there were about those Hippocratic times, when one thinks about this content, one can say, yes, right? There's some very serious and important content in there. Especially this idea of beneficence and non-maleficence, do good, do no harm. I mean, that's really the spine, the bedrock of what we do in medicine, but also notions of integrity are so important, confidentiality, and not exploiting the patient's vulnerability. So there's so much we can be grateful for in that tradition and align ourselves with that in one way or another. But what I'd like to do today is to offer some rather big picture overview remarks. And I've got a fair number of slides here. I'm going to try to make it both relatively expeditious as I work my way through the material without rushing. It's kind of like, those of you who are musicians, when you play things that are allegro, it's one thing to play them well on the speedier side. It's another thing to make the audience know that you're feeling very rushed and you're stumbling over yourself. So I'm going to try to work through terrain, but to land on certain key areas. And what I have in mind here is especially these kinds of big picture words that, at least in my mind, if somebody were to say to me, well, what's most important for the Hippocratic tradition? When I think about the big picture content areas of what it means to practice within the Hippocratic tradition, as we understand it today in what we care about in the organizations that are a part of this meeting, I would say life is obviously key. And I'm not going to talk about that because I take it for granted that a deep, deep respect for life at all of its stages, in all of its conditions, is a given for our gathering. Health is an area that I mean, obviously, all of us in healthcare spend a lot of time thinking and talking about and trying to promote health. But I wonder how many of you have actually tried to define it. If somebody pressed you on, okay, which things should be within healthcare, which things should be outside of healthcare. I'm going to be touching on some of that with respect to this idea of concepts of health. Conscience is going to be the sort of the consistent interweaving theme throughout the entire presentation. And because I'd like to make a lot of connections between conscience and conscientious practice, and especially ethics and ethical frameworks and ethical reasoning, but also connected to concepts of health. And it's also something, of course, that we don't just ask for ourselves, but we also, of course, grant to our patients. So we would never impose even what we think is really good for our patients on our patients against their will. So there's a mutual respect a mutuality regarding freedom. So, first, let me talk about conscientious practice as part of the moral dynamic of shared decision-making. So what do I mean by that? This is a version of a slide that is perhaps one of the most common slides I use in my teaching in medical ethics, because I like to be a big picture sort of person, but I also like to be practical in my big picturedness, and I will sometimes even draw out this diagram when I'm meeting with a family, say in an ethics consultation, because I think this basically summarizes all the major domains of what we should be talking about with our patients in any good informed consent sort of dialogue. So I think many, if not all of you, would do this intuitively because this is what you've learned to do. But it's sometimes important to tag these things so that, especially if there might be some differences of view, we can better understand why those differences might be happening. So we start with something that's given. So there's what's the it that we're talking about. We want to go somewhere, so-called goals of care, which are so important, and thankfully increasingly emphasized in healthcare discussions today. And we get from where we are to where we want to go through some means, right? So I'll be touching on means to an end. But there's always, of course, in healthcare, discussion about probabilities, right? It does make a difference whether there's a 5% likelihood of something versus a 95% likelihood. That does change how we choose. Likewise, what about level of treatment burden or suffering? Not suffering due to the condition itself, but suffering due to the intervention. That matters. I put costs sort of in the gray shadows because for me, my take on this is it's a separate, important but separate discussion. And it's my way of tagging that I don't think that costs should be part of bedside or clinic side discussions unless the patient or family wants to introduce those. So I take costs seriously, and going into debt for healthcare costs is a very serious matter for some people, right? But I don't think that we should be managing society's cost problems at the bedside. So it's not a question in all of this of whether morality is in medicine, but how. In all of these domains, there are ethical values and beliefs that are coming into play. So for anyone who has ever, if you ever hear somebody say, well, you should keep your ethics out of this medicine and healthcare domain, I'd say it's impossible to do that. All of these domains are loaded with value. Now, granted, if you're a pathologist looking at a slide and you say, this is, lymphoma, ... Yeah, I understand it. There's a certain sense in which some things descriptively are in that realm of science where you could, in one sense, separate ethics from it. But how we value what goals are worthwhile, what probabilities are worth counting on, what treatments are worth bearing, what burdens worth bearing, what costs incurring. Now, this whole scheme it should be entirely familiar to all of us. And so I would say to the students, who are the students in the room? Okay, we've got a number of you now. How do these dimensions explain why you are a medical student? Now, I won't call on any of you to answer that question, but I'll answer it for you. So you might be saying, oh yeah, I should have looked at that last slide for a bit more. So that's just to refresh your memory. Okay, but I'm literally about to tell a very brief story to explain why the medical students in the room are medical students, okay? So you see those. So the first point here is to say, what's this? Well, your condition is that you're a human being with a destination of some kind. You're looking for something to do, right? Because that's part of the purposive aspect of being a human. And so what would this be? You're a medical student. What's your goal? To become a doctor? But it's actually more than that, right? I mean, it could be that was your goal, but you actually want to do what? You want to heal people. But that immediately tells you, did you have to go to medical school as the intervention to help or heal people? Sure. Social work, nursing, PA. A lot of ways to help people in a healing way. So yes, there's a sense in which medical school is the end. The healing, becoming a healer is the end. Medical school is the means to that. What are the odds that you can get into medical school and through it? Surely as you were thinking about applying and doing all the pre-med stuff, you thought about that. How much suffering are you willing to go through to get to that end on that probability? And of course, the punchline is, How much debt are you willing to incur to get to that goal with that amount of suffering on those odds? This explains good human reasoning and decision-making. We do this because that's part of how we've been made to use our minds well. Right? So there's nothing novel at all about this. I actually find in non-medical contexts, my mind routinely goes to these structures when I'm trying to work with anyone on a difficult decision that's being entertained. So I recommend it to you, and I think you already do this, right? And even in other contexts you would. So one quick example of this would be, I remember being in a family meeting being led by an ICU doctor in a case of a gentleman who had attempted suicide and now was having various metabolic derangements, was already on a ventilator, also had renal failure. They were wanting to start dialysis, but the family was resisting because the family said, we don't believe he would want to be on life support. And we don't think it should be, in fact, they had reservations about the mechanical ventilation, but they also suggested that hemodialysis would not be appropriate. And it was it's so clear that as that ICU doctor was speaking, that ICU doctor was making claims, ethical claims, basically, about the value of what goals are worth striving for, what probabilities are worthwhile, because that ICU doctor said there's a 50-50 chance of a full recovery with full treatment, right? So that ICU doctor, any of you are ICU doctors, those are good odds, right? And yes, of course, there's a level of treatment burden. He's already on a mechanical ventilator, and being an ICU patient is a very burdensome enterprise. But again, believing that that was worthwhile because the goal of a cure, now it's not going to cure the depression that caused the suicide attempt, larger picture. But the point being is that that conversation, even though the ethical values might not have been tagged directly, was fully loaded with ethical valuation, right? So for anyone who says somehow doctors could keep their values out of healthcare, it's just actually impossible to do because medicine is a value-loaded enterprise. So in terms of means pointing towards ends, we don't only speak of the goals of care, which are, I would call them the more proximate end that's being strived for, but goals of care, of course, are oriented towards health. Health, now if you want to then tell you, well, what's health good for? Well, it's part of human flourishing. So this shows if you want to be really, to use the fancy word, teleological, oriented toward that telos, that final telos about human flourishing is the final sort of word. As experts in healthcare, of course, we focus here. We also focus here, but this is part of where things can get contested, as we'll come to. I think it's important to keep in mind the idea or language of means and ends, but the end we tend to focus more immediately on sort of around here. Okay. So when I talk about goals of care, in case anybody's wondering, this is what I have in mind based on some empirical work that colleagues and I did in the past. This was drawn from some end-of-life literature. But these goals of care encompass a huge amount of terrain, and you might have the goals of care that you talk about, but I think we should be able to answer a medical student when they say, okay, we need to have a goals of care discussion. What do you mean by goals of care? It's important to be able to actually specify that. And by the way, if anybody wants to email me in the future to get copies of slides and whatnot, I'd be happy to do that, so feel free to contact me. So I mentioned, concepts of health. There's a lot of literature among philosophers and others who have written about this terrain. And this, if those of you who like some heavy bedtime reading, you can look this book up. My way of rather somewhat sort of superficially stating things is that you could divide concepts into what in the technical philosophical terms would be called naturalist versus normativist, or I would call it more straightforwardly biostatistical versus well-being. So there's a sense in which we can say the patient is the object of our study, and this is basically what we learn in medical school, right? Anatomy, physiology. We have a sense of the distribution of normal, right? The well-being of the patient, of course, is the idea of illness as opposed to disease. And as I'm going to suggest in a moment, there's always a mixture of these things together. But we take the biological givenness, especially in the physical aspects of health, very seriously. So if somebody wants to make a claim about health that we think contradicts our understanding of biological reality, we are basically making what we could call a biostatistical sort of claim. One of the many examples we could all think about. Once I had a patient who asked me for a prescription for modafinil, which is an alertness-enhancing medication. And this was a young woman who was, by her accounts and my accounts, healthy. But she wanted to do more and sleep less. And she wanted a prescription from me to facilitate that. And we clearly had a difference of view of what health was. I had what I considered a biostatistical view. She had her well-being view. So this, I think, in my mind, is a very nice example of how she wanted to use a means that I could provide to an end that I could not endorse. My suggestion to her, not, which won't surprise you, was it's a natural remedy for your problem. It's called sleep. Right, okay. So another way to talk about this would be to say that there's people who write about it will contrast the inherentist view versus the social construction view. And this is also important because any of you who have read the history of medicine will agree that certain diseases or illnesses change over time. Some fall by the wayside, some emerge. So there is a sense in which some aspects of the boundaries of health and disease are socially constructed. So the question is, to what extent do we accept that? To what extent do we say, but there have to be some boundaries that we're not simply going to allow society to cross simply because society says so, right? So there's a lot written. This is a very useful book, actually, the first section on this. That was an international effort to try to wrap their minds about what the goals of healthcare should be. Mark Siegler, you see his name here, at the University of Chicago, well known to many of us in the field of clinical biomedical ethics. He talks about the doctor-patient accommodation. He's written very nice. This is a piece that he wrote some years ago now. But he basically says that every time a doctor and a patient meet, or a clinician and a patient meet, there's an accommodation that needs to occur. Right? There's a sense in which both have to agree to treat the problem that is being presented as a medical problem. And what I particularly appreciate about what Dr. Siegler says is that that agreement on the part of the physician is based both on biomedical knowledge and on standards of conscientious behavior. And he points out that physicians have this as both a professional and personal responsibility. He does not divide the professional from the personal. He recognizes them as being integrated. So that's one nice model that speaks to this. In some of the work that I've tried to do, I put this sort of schematically, and I know that much more can be said about this, but there is a sense in which every time we meet a patient, we have, now I know that we don't only have a biostatistical view, we also care about the patient's sense of their well-being, but there is a sense in which there's a lot being integrated whenever we meet. On the flip side, for instance, one example would be, let's say if my patient has a very high LDL, and I quickly, reflexively say, sir, I think you should be on this drug we call a statin. If my patient says, doctor, my well-being is just fine, thank you, you're giving me a problem I don't have, because I feel well. Until I can persuade them that this biostatistical side is important, it's a no-go, right? So that accommodation is genuinely important. There has to be a shared understanding. Let me shift gears now to the ethical reasoning side of things. And Donna had suggested that it would be helpful to particularly tag issues related to utilitarian reasoning. It'd be interesting if we had more time to hear what all of you think when you hear me or somebody else use the word utilitarian. I hope that I'm about to say a few things that might add to your understanding in some ways or another. To begin, I'm going to ask this question about considering the kinds of ethical reasoning that guide assessments of what physicians should do when physicians are faced with requests that are believed to be unethical. So this is a theme very much related to conscientious practice. And I would suggest that usually when there's an acknowledged conflict between a physician and a patient in this context of conscientious refusal, the proposals are usually one way or another to try to balance respect for the clinician's integrity with the promotion of the patient's so-called autonomy, right? And you can see the four examples or levels of this that I've written there, and I'm sure this is very familiar to folks in this room. And what I'd like to focus on for a moment is particularly this idea of facilitating treatment by referrals or transferring care. And to illustrate that, I put up here the front page of a legal case from Ontario, and I know we have at least one person in this room who is all too familiar with this case, and I've had some occasions to speak to some of the people involved in this. But what was at issue in this case is the fact that there were some physicians listed here who are unwilling to provide what the government called an effective referral for practices that they had serious moral and religious objections to. And the government basically was quite willing to try to impose its will on these physicians, even at the risk of their medical licenses, right? That case has been appealed, and I understand that before long we will be finding out what the final outcomes of that process are, but it's been a very good example of appropriate engagement using the appropriate legal means to resist and to contest the use of state power to impose upon individual clinicians the state's will, to force them to do something that they believe they cannot do. And so now I'm going to talk about this idea of referral and how this is connected to utilitarian reasoning. That might not be immediately apparent to perhaps some of you. So referrals and the moral seriousness of actions, intentions, and outcomes. So physicians who refuse to make such referrals believe such referrals make them responsible contributors to a process that aims at a goal that is morally objectionable. So I refer to this as an arc of intentionality that is believed to be immoral. It connects request to referral to treatment. Right? Because there would be some people who would say, if you were a conscientiously objecting physician, listen, it's the patient who wants it, and it's some other doctor who's going to do it. What's the problem? You're just kind of helping out a bit. But you're not doing it. You're not desiring it. You're just sort of in the middle there. Well, obviously, that's not something that we appreciate, because we disagree with that, what we would say is a mistaken understanding of part of the moral life. So, there's someone, a Cambridge philosopher named Bernard Williams, who I first read him many years ago when I first started reading these sorts of books, and he writes very helpfully, actually, about what's at stake in that kind of mistaken utilitarian reasoning. And what he focuses on is what he calls, in a technical sense, our moral projects. Those actions and goals, specifically goals that we identify ourselves with in the moral life. And he makes it very clear that we are not merely channels for a larger causal stream that aggregates the sum total of everyone's interests and satisfactions. Right? Final outcomes are not all that matters. How one gets to an outcome and who contributes to it are also morally relevant. Right? So he also points out, my paraphrasing him here is to say that individual moral responsibility is vital for understanding the significance of conscientious objection. So who we are as moral agents, as individuals, is important. And that value of individual integrity is irreducible. It's not merely one interest among others. And I'm going to give some further examples later on connecting to conscientious practice also to human dignity. So I'll hold off on that a bit. Another example I want to use quickly regarding utilitarian reasoning has to do with population health. I'm sure many of you in this room have heard how frequently this notion is used. My reading of the literature on this is to say that population health is really trying to merge or integrate patient care and public health. And it includes, as you can see here, reducing per capita costs. My concern with population health is it is an example of a dual perspective. And I believe it actually is calling upon us to wear two hats at the same time. I like to refer to what I call role fidelity. What is your role when you're a treating physician? Is it also to manage society's resources? Now, I know some of you say if you're ICU doctors or ER doctors, you have to triage. So you sometimes do have to manage a limited resource in real time. Those of you involved in transplant medicine, you do that at sort of national, distributive sort of levels. But for most of us, I think it's really important to keep in mind that we have a primary advocacy role for, in one sense, one patient at a time. I realize when you're in clinic or in other contexts, you actually do have more than one patient at a time. But you see what I'm saying, is that society has a very important problem on its hands regarding costs. I acknowledge that, and I'm glad it's somebody else's really good problem. And I hope they're really skilled at doing their best to figure that out in a just way. But I think part of a democratic spirit is to have sort of a representative advocacy so that each patient has at least one person in their corner on their side. Another way to think about some of this would be to say that you're familiar with these kinds of words like beneficence and justice. Now, on the beneficence side, one, I think, very accurate way to think about the relationship between utility and beneficence is to say that utility is trying to maximize beneficence. I think that's an appropriate way to understand what utility is. It's maximizing it across some kind of a group, as opposed to one person at a time. Likewise, justice is a big word. It has many different definitions, potentially, but there's a very ancient sense in which, and it's the fancy word is commutative, giving to each what they are due as persons. And in healthcare, it's to each according to their need. There's also the distributive sense of justice as fairness, right? And so with this next click, what I want to suggest is that from the perspective of the patient, beneficence and the commutative sense of justice are patient-centered, whereas from society's perspective, utility and distribution give you a different perspective. So I think we need to be clear in our own minds and with each other what our primary focus is. Not to deny the importance of the societal view, but if it's not my immediate responsibility to do anything but be a great physician for my patient, I need to stay focused on what my role is and practice fidelity to my patients in that way. So, last thing, I think, almost the last thing here about means and ends, is to say that it's not only, of course, utilitarian reasoning that talks about means and ends, but it's also very much virtue-based reasoning that talks about means and ends. And a good way to understand what practical wisdom is, whether it was Aristotle's phronesis or Thomas Aquinas' prudentia, it's pursuing worthwhile ends and finding the best means to achieve those ends, okay? And so as you can see here, what I'm trying to point out is that practical wisdom takes both means and ends seriously, but believes both must be ethically justified. By contrast, in utilitarian reasoning, the ethical work is done to identify what end should be pursued, whether it's happiness, whether it's power, whether it's beauty, whether it's money, some end. And then, of course, you know the phrase, the end justifies the means, right? That's that sort of quintessential line. Whereas in virtue-based or other principle-based, we would never say the end justifies the means. Both have to be justified. So that's another point about utilitarianism. Last point about this, I draw from Leon Kass. And in one of his many important essays, he talks about how important it is to not to succumb to a view of medicine that focuses on medicine as a means detached from ends. And his fear in this essay is that's exactly what's happening. We have all these technological means, but it's like you have a ship without a compass or a rudder, right? There's this sort of a wandering wherever things may go. And what you can see here by this is to say that if you have just, means that are detached from ends, you basically have these powerful treatments and tests, but you don't have a sense of where they're going. And then if you can't agree on the end, though, you're even more in trouble, right? So to the extent that we will also have different visions of health in our society, we also have the challenge. So one is to have the means detached from health, but the other is you might have different views of health. Now some comments about moral integrity. I don't know how many of you would do this, but I've come, over the years, having thought about conscientious practice and conscience, I basically treat conscience and integrity interchangeably as conceptual sort of ideas. And And that's what is part of what's behind what I'm about to suggest. So if you look first at conscience, so just you look at a Webster's dictionary, you can read that. I think it's a pretty helpful basic definition from the dictionary, right? But what I want to quickly go to is a more sort of philosophical approach that was developed by a well-known philosopher in this area named C.D. Broad, who basically said that there are three dimensions to conscience. There's a rational dimension, an emotional dimension, and, as you can see here, a motivational one. And I don't know how many of you would say, yeah, that's exactly what I thought, or whether you might say, oh, that's actually not how I would have thought about it. But I would suggest to you that if you think about the last time your conscience was active in your life, you'd say, yeah, my conscience was involved in helping me understand why something was right or wrong, good or bad, right? It was also making you feel something, especially maybe some guilty feelings, right? Right? If it was on the unstable side of things, but it was also motivating you to resolve whatever needed to be resolved, right? So that's the unusual nature of this thing that we call conscience. This is a wonderful book called Conscience and Other Virtues by Douglas Langston. If you ever wanted to read one book on conscience, this would be the one that I'd recommend to give you a sense of the history of how conscience has been understood or misunderstood. And these comments I draw here are related to what I was saying about C.D. Broad, and it says a bit more, though, but it basically talks about conscience as a relational entity, not in the sense that it helps you relate to other people, but in us, it's a relational entity. There are different facets relating to each other, and it involves intellect, will, memory, emotions, desires. It's unique and irreducible. It has to do with our ultimate goals, and it also is very closely related to the practice of the virtues. So conscience is very much in the thick of basically the things that are most important to us as human beings. There's a paradox of conscience, which I think is actually really important for all of us to appreciate, and that it is both authoritative for each one of us, and it's also fallible. Because many people would say, wait a minute, that's a contradiction. Well, it's a paradox. It's a seeming contradiction, right? So the point being is that because of the nature of conscience and because it represents your moral best, it means that it would be irrational and wrong of you to do anything but your moral best. So you can't do better than your best, but you also know, in actual fact, your conscience could be wrong from some other vantage point that you don't currently have access to. Has it ever happened to you that you've made a decision, you've done something in life, and at the time you believed you were acting conscientiously, and at some later point in time, you look back and thought, no, actually I shouldn't have done that. And it's probably because you lacked the information that you now in retrospect wish you had, or you might realize that your conscience wasn't as well formed, as well as not being as informed as it should have been. So when we make claims of conscience, we're not claiming to anybody, I hope, hey, I am perfectly right. That's why you should respect my conscientious decision on this. No, what you're saying is, this is the best I can do. And I ask that you respect that. Right? You're not claiming absolute knowledge and goodness. You're just saying this is the best that you can do. All right. Related to integrity, even some of you will recognize the authors here, Beecham and Childress, of the famous Principles of Biomedical Ethics. They have some nice remarks about integrity, and they talk about it as that which integrates our moral character, and as being a matter of soundness, reliability, wholeness, integration. And this idea of wholeness and integration goes back a long way, and this is a wonderful quotation from Plato, right, where he says, "It would be better for me to have a musical instrument or a chorus which I was directing in discord and out of tune. Better that the mass of mankind should disagree with me and contradict me than that I, a single individual, should be out of harmony with myself and contradict myself." So I play the violin. I know what it is for an instrument to be out of tune or my fingers to be landing in the wrong spots. It's very unpleasant, but think about that deep cognitive or moral or existential dissonance that is being out of tune with oneself as oneself is meant to be. Another example of this actually comes from Dietrich Bonhoeffer, as you can see here. His understanding of conscience is very, very important. And in the middle he writes, we should always follow conscience because it comes from a depth which lies beyond a man's own will and his own reason, and it makes itself heard as the call of human existence to unity with itself, and therefore protests against doing anything that imperils this unity. In fact, he goes so far as to say that to act against your conscience is to effectively destroy your own being. That's how deep integrity goes. Okay. Saying a bit more about ethical reasoning here and its connection to conscience. So I already talked about rational, emotional, motivational. Have you ever reflected on, say, being at a committee meeting or somewhere else where somebody will say, well, I don't feel comfortable with that? Have you ever wondered why that person didn't say, I don't think that's right. I don't think that's right, as opposed to feel comfortable. We actually live in a culture where this idea of feeling actually is the more accepted way of expressing our differences. And feeling can play into mistaken understandings of conscience. Actually, feeling's part of it, but it's not the total of it. Reason is a key part of it as well. So in the Catholic tradition, there's a very close relationship between practical reasoning, moral practical reasoning, and conscience. I won't go into that further, but just to tag that, so that I think those of you who come from the Catholic background, you've been raised in this sort of an understanding. It's interesting, in the history of conscience, there's also been tendencies to separate conscience from reason. Some of you might know the name Joseph Butler, you know the name Immanuel Kant, and this I draw this from Douglas Langston, who says, by the 19th and 20th centuries, there emerged a widespread view, aside from the Catholic view, but otherwise a widespread view of conscience as a faculty separated from practical reason. I think that lives on very much. And whenever you hear people suggest or claim that, hey, your conscience is sort of your private matter, it's like your feeling, it's like your tastes, as opposed to part of your ethical reasoning. Very different statements are being made there, right? So, if we agree that reason is part of conscience, then it allows us to say that whenever we're making conscientious claims, we're actually ready to engage in ethical reasoning, and that's exactly as it should be. So as you can see here in the middle, what I would hope that we all do whenever we're making conscientious claims is we're communicating two things. One is we're telling someone, our discussion partner, how serious this matter is, that the matter rises to a level that could not be more serious for us. But it is also a rationale for a conviction, and so we're ready to start engaging in moral reasoning and explaining ourselves. So conscience should always be part of dialogue and deliberation with others. This was from a news item you might have heard about. There was a nurse at Guantanamo Bay who refused to participate in the forced feedings of hunger strikers. And what's interesting here is that the American Nursing Association came to the aid of this nurse, to defend this nurse, and you can see there the language of arguing, of saying that the nurse was making an independent ethical decision and expressing an ethical objection, but notice how the Miami Herald described this as a crisis of conscience. It's a very nice example of how, at least when you agree with the ethics that's being represented in that conscientious objection, you're ready to say, yeah, this is an ethical matter, as opposed to, oh, it was just the nurse's private sensibility. That's not at all what's being said here, right? That's the point. So I'm very appreciative of this, right? So I would actually suggest that everyone is pro-conscience, but people disagree about when someone should act on conscience, and they do so on the basis of their ethical judgments about what's at stake. So whenever we talk about conscience, we need to, I think, distinguish between our assessments about what conscience itself actually is as part of our human reality, as well as, by contrast, our ethical judgments about specific clinical practices. Right? So people tend to support conscientious action when they agree with the action that was being done. They tend to have reservations or worse about conscience when they don't like what the conscientious objector was the fact that that person was objecting. Are you follow me? Okay. So, a bit more on the human dignity side. I mentioned the Bonhoeffer comment and say a bit more. This is from Martha Nussbaum, a political philosopher and a public intellectual in our country. And it's interesting, in her book, she talks about conscience in the same, sentence as soul and human dignity. So there certainly are traditions in our widespread sort of secular and philosophical culture that acknowledge how deep conscience is. And she even says, infinitely precious. You can't do much better than infinite, can you? Right? And I'll come back to Nussbaum a bit later, because she draws certain boundary lines about how far conscience should go in a way that we would not. But another example, say, from the Catholic tradition. Joseph Ratzinger, before he became Pope, spoke and wrote about conscience, and referred to conscience as a kind of co-knowledge of man with God, from which arises the absoluteness with which conscience asserts its superiority over any and all authorities. Right? That's how serious it is. And now, if I may, from the Protestant side of things, from Barth and Bonhoeffer, and summarizing them sort of together, for both, conscience is intimately related to the human need for God and requires a responsiveness to God through faith and obedience. So we can't be talking about things more basic, but once again, even though many of us will, if anyone really wanted to know what we think and believe about such matters, we would speak in terms of our religious belief and of our faith. But this is certainly something that we can also communicate about in terminology that is also easily accessible to others in our culture who don't share our beliefs. Given how serious conscience is, it to me has been very concerning when I have sometimes read in some medical journals that talk about conscientious practice, the suggestion in this first bullet up front that you could somehow presume to separate professional conscience from a person's individual conscience or personal integrity from clinician integrity. I confess, I just don't understand how that could ever be contemplated. I get the point of what the authors are saying, but I disagree deeply with their moral anthropology about how we are constituted. Right? I'll come to that a bit more. By contrast, someone like the great philosopher Charles Taylor talks about the need for unity in the moral life, for an undivided self. And then Alistair McIntyre talks about what happens when you don't live at unity with yourself and you have a divided self, and he calls this compartmentalization. That essay there is well worth every dense page that it's comprised of. It's a wonderful essay about something that's very real, especially for medical students and trainees, about how there can be a lot of pressures to compartmentalize yourself to try to fit into what's being expected. I also think that compartmentalization can lead to moral distress, which is a phrase that you've heard a lot about these days. And I just point this out here, just this is another nice reference if anyone want to read more about moral distress. But the point about distress is that especially when it's external and situational, it occurs when people make moral judgments about the right course of an action but are unable or unwilling to carry it out. And there are obviously costs when that happens. There's also, I think, grounds to make a connection to the whole burnout discussion in this regard. And that is to say, of course, that though there are many causes of burnout that people in this room are sadly all too familiar with, one of them is also what some would call the values gap between your values and your organization's values. And as some of you may know, there are 3 domains of burnout. The most commonly referenced one is the emotional exhaustion, but there's also one that used to be called depersonalization, now cynicism, which is a lack of congruence of the individual and workplace values. I think this is another reason why some people might also be getting burned out. Take this for what it's worth, but one way that I've thought about putting these ideas together is to say that we all come to our work with moral values. We encounter ethical challenges and obstacles, not just in work, in life, right? This is part of being a human being. That leads to moral stress. Right? You lift up a weight, you're exercising, that's stress. So sometimes you go after stress, right? Stress is not necessarily bad. But it can become moral distress. And it can lead to cynicism, compartmentalization, and it may contribute to burnout. By contrast, if it leads to communication and engagement, then it can lead to resolution or recalibration. And that's part of what I think we mean when we talk about conscientious practice. So I think a lot of these things are connected, and these are just more reasons for why we have to reckon with this. Did I see a... Okay. So, some rapid remarks about moral pluralism, because this is the wider context that we're in, of course. And I'm going to go through this rather rapidly, because I'm sure a lot of this is all too familiar. But I like to refer to foundational beliefs and values as the deepest sort of core ethical stuff that we have. And people like Paul Ramsey, Jeffrey Stout, and John Reeder have talked about these values that we all have. And so whenever someone somehow might make you feel or think, wait a minute, am I different because I have religious beliefs and values, especially this work by John Reeder, he points out the obvious, that we all, no matter whether you consider yourself religious or not, you start from somewhere. You have beliefs about what you believe is ultimately real and ultimately good. So whenever you're in a conversation with someone, we should never be made to feel that we're the ones who have these kind of claims, but somebody else somehow doesn't. We all do. So we need to level the field and ask each other questions about, so how do you justify universal human rights, right? If not the way that I do based on my religious beliefs. All right. One quick example of this would be from physician-assisted suicide and euthanasia. I'll just let you quickly glance at that list. That's about foundational beliefs and values, right? Harrison's textbook of internal medicine will not answer the questions posed by these values. Right? This is not science, this is value loaded. And so when you look at data from the state of Oregon and look at the reasons that people give for why they request prescriptions, most, if not all of these reasons at one basic level, I know that pain, to the extent that that is a medical issue, I understand that, but look at these here. These are existential concerns. So to somehow suggest that assisted suicide is legitimately medicalized, I think is suggesting that those of us who went to medical school had a course in existential beliefs. Though I of course am opposed to physician suicide, one could suggest that if it were to be supported by society, it would make more sense to have pastor-assisted or priest-assisted suicide, because they have expertise, at least, in matters existential, right? You see what I'm saying? Okay. So, I also believe not only is this the landscape that we're in terms of pluralism, but also it's important, I think, for us to remind our colleagues, whoever they may be, that what we're talking about in conscientious practice is also good for society. That's important to keep in mind. Right? And people will talk about this in various ways, and I give a couple examples here. But certainly it leads to more critical reflection, more dialogue. Some have even drawn a parallel between freedom of conscience and freedom of speech as being a basic good in society. And I think we need to remind people that if we don't do this, there's a real risk that, as you can see on the last sort of bullet here, that if professional or government control over morally controversial areas of medicine is allowed, it will lead to a uniformity of practice that may stifle further thinking and discussion. Right? So these are serious issues, and we have to remind people that true to the democratic spirit is to have a genuine diversity, at least, that is allowed to be part of the discussion. So now the question of how much accommodation of our differences. I mentioned Martha Nussbaum before. Now here you see the limit she places. So yes, freedom of conscience limited only by the infringement of others' rights or compelling state interests. But then my concern here is, if society can't agree on our foundational beliefs and values, how can it reach consensus on what constitutes an infringement of rights or a compelling state interest? How will we agree on what is allowed to be considered a morally controversial practice? Hence the importance that many of us place on who gets placed on the Supreme Court. Because, lo and behold, human beings will be making these decisions. And that's the best our society can do in terms of adjudicating those kinds of differences. There's also something curious. If we were to allow people to suggest to us that, well, you know, your integrity or your conscience is problematic, when you read certain people who talk about the so-called contract with society that medicine has, these authors, and I think many others, would suggest that society expects our services, but also our altruism and our morality and integrity. So it'd be a sad irony if our integrity was desired until somebody didn't appreciate its implications. Right? So this is actually part of what should be understood as what we're doing here. Others at this conference will be talking about legal accommodations and conscience clauses. I won't say more about that now. So we need dialogue and ethics and motivation. And I think one of the things that we really need to keep reminding others who want to hear what we have to say about conscientious practice, that conscience is not only about what things we withdraw from because we can't participate in it, but also what things we are drawn to, right? And so this last point here, when I say that conscientious non-participation should not be viewed as patient abandonment or obstructionism, but as a considered response to a serious ethical disagreement about what is in the patient's best interest and what constitutes a health need. So it's not about just what I don't feel like doing or what I find awkward or uncomfortable. It's actually what I believe is good for my patient, and I want to be drawn towards actually being a healer. I'm just going to give quick examples that I've encountered, and this is de-identified. And so I'll say, once upon a time in a hospital somewhere, there was a gentleman from another country who was not in this country on legal terms, developed aplastic anemia. As most of you will know, it means the bone marrow has shut down, no ability to pay. And this was a remarkable example of a lot of healthcare providers from different domains who tried their darndest to get this patient a bone marrow transplant. And this is a great example of being conscientiously driven to go up against rather strong institutional financial pressures that would basically say, we will do the minimum to satisfy EMTALA, but we don't have the money to pay for what you and I would get if we were in this shape, right? So that's the positive side. How about once upon a time somewhere I was addressed by a very tired, overworked, frustrated intern who was more than frustrated, was actually distraught by the fact that she had to care for a gentleman who was not only a drug user and had endocarditis, but was a drug dealer. And she was saying, why should I have to care for this man when we're going to get him better, he's going to go out on the street and cause the death of more other people? And to make matters worse, she said, my own parents are immigrants to this country and don't have health insurance, and this gentleman is getting our tax-paying dollars to pay for his excellent care. So you can imagine that was an interesting moment for me to decide, how do I respond, right? And so, of course, I said, listen, you've voiced some powerful reasons why you might not care for this man. You better have some very deep reasons to actually override that and recognize the dignity of your patient and their healthcare need at this time, right? So the depth of the need for conscientious practice in a situation like that. Once upon a time, somewhere in a hospital, one might have heard a story of a student who is at the bedside of a patient who's encephalopathic, needs blood gas done. The resident successfully achieves the blood gas sample and then turns to the student and says, this would be a good opportunity to practice. Would you like to do one? So a student with conscience says, wait a minute, this is not healthcare. This is using a patient merely as a means for my educational benefit. And I thought I heard a lecture that said we're not supposed to do that. Imagine the pressures right on that student to conform to the obvious expectation. So we don't want medical students of conscience who now have the ability to say something to get out of that situation because it's clearly not the right thing to do. How about once upon a time, somewhere in a hospital, an attending physician is told by an administrator, it's time to discharge your patient. And the attending says to the administrator, but the patient, we don't have any outpatient dialysis arranged yet. It's okay, send him out. He goes back home to the neighboring state. He'll work it out with somebody over there. And this attending said, no, I will not discharge the patient. Right? And the pressures to conform for length of stay, et cetera, right? And this is a more lengthy one. I won't go into it now. I think in the interest of time, let me just end with this slide that says, conscientious practice should be respected as a matter of human dignity, understood as a matter of moral integrity, engaged as a matter of ethical reasoning, situated within the moral dynamic of shared decision-making, accommodated as a right and a good in a morally pluralistic society, and sustained for the flourishing of the health professions and the care of patients. So thank you for your time, and thank you.